with RLM. Reza loves Maria. As you can see, Robbie will be here, and I think in like 5 or 10 minutes. But good morning to everyone. I hope you are all having a lovely Friday and have some nice weekend plans, and you get some time to rest and take care of your body, mind, and soul. But it's time to get to business. Who has a case that they'd like to present today? And then Maria, should we do it just old school with no scribe and just listen to the general idea? Is that okay? Awesome. Awesome. That way we get to see all these lovely faces as we're teaching and hearing about the case. Hi, Scott. So anyone have a case for today? Oh, awesome. Robbie, if you can scribe, that'd be wonderful. If you can take over the template, that'd be great. Thank you. So I'm not afraid of silence. In fact, I made myself an egg burrito. So as long as no one is volunteering, that means I get to eat this egg burrito. And I ran out of clean spoons, so I estimated the coffee today. And do you see how thick and viscous it is? I haven't had any of it yet. Once I start drinking this, I will be jumping off the walls. Exactly, and it's not the thyroid tremors. Anyone have a case today? Oh, does someone have it? Oh, wonderful. Nikita, please unmute yourself. Say hi to the audience. Tell us where you are.
Yeah. Hi, everybody. I'm Nikita. I'm from India. I'm a recent graduate. And yeah, I've been around with clinical problem solvers in the past month, and I've thoroughly enjoyed solving all the cases. And today I'm going to present one. So I'm excited for this.
Awesome. Thank you so much for volunteering. We are very excited to discuss this. And maybe I'll have our dear friend Ravi take over the screen. And then once Ravi takes the screen over, please, Nikita, whenever you're comfortable, start presenting and stop whenever you want.
Yeah. Okay. So yeah, I'll start presenting the case now. So I saw this case 2 years ago in the ER. So this was around the time when my country was experiencing a second wave of COVID, and it was during the time when the restrictions were just coming off, and people started leaving their homes again. So it was during that time. So yeah, I was in the ER, and it was my 24-hour shift. And mid-afternoon, a patient was brought in a stretcher. And when I spoke to the patient, the first thing he said was he hasn't been able to feel his legs, and he hasn't walked since the past 2 weeks. And he's a 49-year-old male. So I think you can start from there.
Oh my gosh. How scary of a chief concern is this one? And Nikita, thank you for setting the story up. I feel like you're telling a story and it's very engaging. This is frightening. And I'm gonna first start with a pearl for all of you that I learned from one of my mentors. And it's the following. Anyone who walks into the hospital with a myelopathy, should be able to walk out of the hospital. What does that mean? That means that nerve tissue, just like cardiac tissue, its function is dependent on time, meaning time is tissue. I wanted to say time is money because I've been thinking of finances, but it's really time is tissue. So in this case that Nikita is presenting to us, it's going to be really important to know how this patient arrived to the hospital. But basically, the problem that my mind is solving is bilateral lower extremity paresis / paralysis. And what did Aaron Berkowitz teach us about the neurologic DDX? It's equal to time course times localization. So right now, we need to dive more into the time course, but we can already make some progress on localization. Where could the problem be? And this is what's amazing about neurology, is that you can make so much progress and have so much discussion with just a few words. Neurology, you break down for localization into upper motor neuron and lower motor neuron. It actually really helps to go through this exercise because it will navigate your history taking and will navigate your physical exam. So upper motor neuron processes, here we're referring to the brain, the cerebellum, the brainstem, the spinal cord. So the brain as a whole and the spinal cord. And for upper motor neuron processes, these patients tend to have hyperreflexia, but you got to be a little cautious there because in the hyperacute setting, they may actually present with hyporeflexia. But eventually you develop hyperreflexia. They have upgoing toes or the Babinskis. They may have clonus. They may have spasticity. What the lower motor neuron signs, what we'll be looking on for physical exam is going to be things like hyporeflexia. It's going to be things like fasciculations, muscle atrophy. And the lower motor neuron portion, this is the peripheral nerve, the junction, and the muscle. But here's the challenge, folks. You can have a problem anywhere along the neuromuscular axis that can lead to bilateral lower extremity weakness. Meaning you can have bilateral lesions in both cortex that cause lower extremity weakness, like ACA strokes that are bilateral. You can actually get masses that are bilateral in the cerebral hemispheres that affect both motor tracts or motor cortices. You can have, of course, a process in the spinal cord, and that's honestly where my gut is taking me. And the reason my gut is taking me there is because of the sensory problems as well. So what I'm most concerned for is some form of spinal cord pathology. And I'll be able to make much more progress once I get a sense of the tempo. Because if it's hyperacute, was it a fracture that then caused a cord transection? Was it a vascular lesion? If it's acute, now I'm worried more about inflammatory processes like MS, abscesses. If it's subacute, atypical infections, for example, nutritional deficiencies. But just for the sake of exercise, we talked about the brain, how you can have a bilateral ACA process. We talked about the spinal cord, which makes a lot of sense. That would also explain the sensory findings. Now, you can also have peripheral nerve processes and even muscular processes, but the muscular processes they rarely present like this, just bilateral lower extremity weakness. Usually there's proximal weakness. So that pattern wouldn't be consistent with this. And the reflexes is going to be really helpful. And then the nerve, specifically Guillain-Barré syndrome, can present like this. Here is another pearl that I learned from Aaron. The bowel and bladder symptoms are going to be as important as the reflexes. Because we know with Guillain-Barré, you don't involve the bladder. With the myopathy, you don't involve the bladder. But with cauda equina, which sort of lives, the horse's tail, it lives in this mixed region of upper motor neuron and lower motor neuron. Those patients have hyporeflexia, but it's those nerves as they descend down before they exit the spine. Maria, please fact check everything that I'm saying. I haven't thought about neuro for a while, but I'm going to pause there. And if I were to summarize the 2 or 3 main takeaways, whenever you have weakness or bilateral lower extremity weakness, try to divide it into upper or lower motor neuron. Use the time course to make further progress, and then use bowel, bladder symptoms and reflexes to really pinpoint into upper motor neuron or lower motor neuron. All right, Nikita. You gave me a few very striking words, so I talk forever. Or maybe I'm just delaying it so that Robbie joins me so I don't flop.
I'm here.
Well,
That was poetry, poetry. But my favorite part wasn't any word that you said, but rather the hyperacute finger snapping. You're a well-practiced, highly effective finger snapper. It's a delight to
Rob, I
see.
have to tell you something really quickly, man. I made coffee today and I never made it this thick. And I haven't even, I haven't drank it yet. So once I
Uh-oh.
start drinking, I'm gonna be jumping off the walls.
I can't wait. We'll see you bouncing for the next hour. I love Ravi's tie too. Hi, Ravi. Good morning.
Yeah, I shall continue the case. So this is a 49-year-old man. So what happened 2 weeks ago was that he fell off from the bed, and the bed was around 1 feet off the ground. And at that point of time, he experienced severe back pain. The back pain persisted the next 2 days until he realized he couldn't really feel his legs, nor could he walk. And he didn't try to walk, and he resorted to the bed for the next 10 days to follow. But within the period of 2 days, he realized he couldn't realize when he would pass urine, and he couldn't realize when he was passing feces. So basically, he had some kind of incontinence, and yeah, because of this, his wife and his son decided that he should wear diapers, and they didn't go to the hospital for 10 days. So they were bound in the house because of the lockdown restrictions and couldn't really move. So for 14 days, this man has not gotten off his bed. And this was the symptom progression. I can move on to past medical history if you'd like me to.
Nikita, one, this is such a powerful story that you're sharing, including details about why he didn't come and just how severe this disease process is. I can just comment briefly on the additional data because I think it's very valuable before you give us additional history, which is there are two threads here, one of tremendous progress and one of extreme caution. And the tremendous progress is, as Reza set us up with the master schema, is to put a lot of value in the presence of urinary and bowel symptoms, which localize the disease process to a sacral neuropathy or anything above. And the sacral neuropathy is essentially a cauda equina syndrome or anything above. And so I think we make tremendous progress in that localization. And the question is, what's the caveat? The caveat is it's of course very tempting to immediately jump to the fact that this person had trauma and then to be mandated to connect the trauma to what happened. But I think one question remains, and that question will clarify that assumption. It's just, how were you feeling before you fell off the bed? Because that would change the calculus tremendously if the reason that he fell off the bed was a neurological process in the first place, and the incorrect assumption of associating the trauma with what happened in that moment is easy to fall into that trap. And one question would provide tremendous clarity. But I think absent that, you should probably use the operating hypothesis that trauma led to this, but have that caveat in mind. And the question is, how can trauma lead to this? First, you probably should localize the lesion, which we haven't done yet. But either way, you're going to image the cord, I think, no matter what you find, given the trauma. And so just be open to the possibility that you may not see overt. What you're expecting to see is you're expecting either to have a vertebral fracture or disc protrusion, but be open to the possibility of less common compressive diseases, like an epidural hematoma, which might happen in this context, especially if you tell us his medical history marries him to some anticoagulative or antiplatelet process. And then the most important thing, again, clinical reasoning is all about knowing what your missteps might be, is if you see no evidence of compressive disease, don't rule out a myelopathy. There are many ways that a myelopathy can result in cord issues without overt compression, including dynamic compression. So an unstable fracture in the right position may not show up, and some other things, which we can talk about if we get there. So to summarize, the urinary symptoms, as predicted by Prof. Rez, are tremendously valuable in their localization, but don't make the false localization of the time course and assume that it began that moment he fell off the bed by asking a key question. How were you before that fall? Anything to add, Prof. Rez, before we get more data from Nikita?
Not at all. That was poetry, my friend. Thank you.
Okay, so at this point in time, I was taking the history from the patient himself and his wife. And the patient explained how around 10 months ago, he has been having mild fevers, didn't really bother him much. And he has been noticing that, he is experiencing some kind of weight loss. And he says that he's not been eating well. He doesn't really have an appetite. And this was around 10 months ago. But then 6 months ago, that is 4 months since the start of the symptoms, he went to the doctor and they figured out that he has some kind of carcinoma, but he doesn't really know what he has, and nor does the wife know what does he have. So anyway, his son is yet to come at this point of time. So they told me to wait until the son comes around. So this was the only piece of past medical history I had, was he has some kind of carcinoma and I do not know what it is. But the diagnosis happened 6 months ago. And 2 months after that, he started chemotherapy. And it was one cycle of chemotherapy was given to this person. And yeah, but apart from that, in terms of past medical history, he doesn't have any chronic diseases, no significant social history, no health-related behaviors, no allergies. If anything, in the last 3 months that he was home, he experienced 2 episodes of fever and cough, but he says that it didn't really bother him. So this is the past medical history. I can go to the vitals now, if that's okay. Should I carry on? Okay, cool. Great. So in terms of physical examination, his heart rate was 64, BP was 100/70, his temperature was normal, and his saturation was 98% on room air. Upon appearance, he was emaciated, but otherwise he was alert, oriented, and all his cognition was fine. In terms of systemic examination, his cardiovascular and respiratory system was all normal, within normal limits. Upon abdominal examination, there was fullness present in the suprapubic area, and I couldn't elicit any abdominal reflexes. At this point of time, since he had a history of trauma, I had to inspect his back, and we log rolled him, and there was no ecchymosis present. I couldn't see any swelling, but upon palpation of all these spinous processes around the thoracolumbar area, he had some point tenderness present. So I would say around T12, he had tenderness. After this, I carried on with the CNS examination, and in terms of his upper limb, he had no significant issues at all. But on examination of his lower limbs, he couldn't actively move his legs, and he wouldn't try to also. And upon passive movement, when I was checking the tone, I could see that at first there was a lot of resistance, but at the end of the arc, there was no resistance at all. So there was some form of rigidity. And in terms of power, he couldn't really, when I would flex his hip, he couldn't really move against it, and same with the knees. But in terms of reflexes, his knees, both left and right knee reflexes, it was very exaggerated. But when I tried an ankle reflex, I couldn't get any. In terms of the sensory system, he couldn't really locate any kind of fine touch or crude touch when I tried to elicit, and he couldn't really sense any kind of joint position. And another thing I can add is that the same numbness per se was not even felt in the abdomen. I would say below the umbilicus. So yeah, that's the examination.
Wow. Nikita, amazing examination. Very thorough, like a are you a neurologist or neurology?
No, I'm just a recent graduate. I'm interested in orthopedics, if anything, not neuro.
Okay. That's awesome. Congratulations on recently graduating. Maybe what we can do is tackle this together, Robbie. I will leave the localization exercise for you in the physical exam. I will talk about the background data, including the past medical history and the tempo. Because remember, we rooted ourselves in the neuro DDX, which was tempo times localization. And it's crazy how even if you didn't look at that physical exam for localization, the bowel and bladder symptoms, like Robbie said, put you north, towards the spinal cord and the brain. And I would say the sensory symptoms took you away from the brain, and now you're just in the spinal cord. So you can make so much advancement. I was saying progress a lot, so I thought I'd use a different word. I'm proud of myself. Advancement with just the history. Now, this tempo, it's tricky, folks. It's tricky because you may have a tempo of this carcinoma and not otherwise specified yet. And I love the fact that Nikita is being very honest with it, because this is how the patient actually presents. The patient doesn't present like those NEJM cases or JHM cases of everything wrapped in a bow. This is real-time medicine. And I think the best way you improve your skills is to really simulate what you experience in real life. So in any case, what I'm struggling with, and I'm going to take both frames for the neurologic tempo, is that this carcinoma may relate to the presentation, either through metastasis, either through perineoplastic. Perineoplastic would be less likely. I'm thinking more structural because of the symmetry that we have, though I'm not excluding perineoplastic. And then I don't know if the 10 months of sort of night sweats, weight loss, inflammatory symptoms is related to the underlying malignancy, or did the patient have this underlying malignancy, get immunosuppressed, and now has an immunocompromised status and has an infection? So I guess like the buckets I'm thinking of here with the background data is this can all be neoplastic through Mets, all of it. It could be neoplastic and then you're immunocompromised and have a superimposed infection like tuberculosis. So now you have multiple processes happening. Or you can also have like peculiar drug effects and perineoplastic phenomenon. So all of those are possibilities. What I do know is that this patient definitely has some kind of background inflammatory process. What I don't know is whether the spinal pathology is inflammatory in nature. I'd like to say yes, but I'm open to that spine just being weak and then a trauma and then a fracture, because maybe this patient got steroids and has osteoporosis. You see? So there's a lot going on. You can't just say, oh, this is 10 months, so it's subacute to chronic and it has to be neoplastic. No, that's not the way. You have to be very cautious how you approach this case. All right, Robbie.
Absolutely superb. I think you made progress on your word of progress, but also tremendous progress on this background progress. I'm just keep saying progress. Reza is actually kind enough to be working with a colleague who's presenting a written case to me. And so I've been working a lot on my writing, and I opened it up because I realized I think I'm using the word on account of so much in that document. But anyway, let's talk about this exam, which I think is absolutely superb. I'll be honest with you, there's no way I would be able to get the amount of data that Nikita is getting to us. I think that neurological skills atrophy, and it's amazing, Nikita, that you're using them to such detail. And let's talk about how the train is suggestive of how the train is moving in one very clear direction, but then is derailed by one very subtle but important finding. So here you have hyperreflexia in the knees, you have increased tone, and you have a sensory level at the umbilicus. That is the definition of a myelopathy. The most specific sign here of a myelopathy is a sensory level. The hyperreflexia could point to a brain problem, and the rigidity could point to a brain problem in general. But when you find a sensory level, that is very, very specific to a spinal cord. The truth is that it's not perfectly specific, as the textbook tells you, because by sheer luck alone, you could only be affecting the nerves down a certain level, but it is usually very, very predictive. Now, what's the wrench in that hypothesis? The wrench in that hypothesis is the inability to get an ankle reflex. Now, if you look over and you say, oh, what's the value of that wrench? It should diminish dramatically if you see two things on the left of your screen. The first is if you see the patient as an older adult. I can't give you a specific age cutoff, but age-related hyporeflexia is very common. And the other thing, if you glance on the left, is the overt reason to have a peripheral neuropathy. The most common is diabetes and alcohol. What I'm saying quite simply is you can remove that distractor from the train if there's a simple explanation for it, like age or diabetes. But here I did that glance and I found nothing. So what are the possibilities? The possibilities are that this patient has a confirmed highly suggestive myelopathy, and this is noise. This just happened to distract you. Or it is telling you that this patient has the camouflage phenomenon. And the camouflage phenomenon came up yesterday when NES presented a fantastic case of a pleural effusion with hypoxemia. We talked about how the hypoxemia can be explained by the pleural effusion, but most people don't have hypoxemia from their effusions alone. They have concomitant lung disease. So the question here is this myelopathy full stop, or is this myelopathy camouflaged with a peripheral neuropathy? Because, when we talk about localization, we're like upper motor neuron or lower motor neuron. B12 deficiency, ALS, paraneoplastic disease, all can have upper and lower motor neuron disease features. So from the diagnostic reasoning perspective, you're asking yourself, is there any additional progress that I can make by solving this as upper and lower? That has to be counterbalanced with being distracted by a false localizing sign. So I'm not resolving this tension for us. I'm merely pointing it out and telling you that you have two options. You either use it as a clue, or you ask yourself, or you tell yourself to be careful. It's just one finding. Is it going to derail your other hypothesis? All right, Nikita, back to you for more data, please.
I forgot to mention, I did try to elicit a Babinski's reflex, and it was non-reactive. It was neither up nor down. Okay, so back to the labs. His hemoglobin was 6, WBC was 2.9, platelets was normal, electrolytes were fairly normal too. I'm just going to say the significant lab values because this was around a year and a half ago, so I don't really have the proper values, but creatinine was 2.5, albumin was 2, calcium was 13, and LDH was 700. I think this is a good place to stop, but I could continue, but the next aliquot might be a dead giveaway. So I would like to stop right now, if that's okay.
Oh, of course, you got it. So I'll just reflect on one thing, which is that the CBC, and then pass the mic to Prof. Rez for the other findings. It may hard to, I'll actually also incorporate the CBC a little bit, but because it's hard not to, because they're kind of related. And so I think the key question is, what is the timing of the receipt of chemotherapy? Because neutropenia and anemia are very intimately related to cytotoxic chemotherapy. So another simple explanation may be that this patient got chemo for their carcinoma. And if you are practicing and you don't know the time course, you should not assume that hypothesis, because you miss out on considering alternate ones. And the reason to push through is to say, well, why is the patient not thrombocytopenic? And so here, you probably, if you're thinking in this real time, you're studying what are the overlaps between neurological disease and cytopenias. And for me, this makes me wonder whether this patient actually has a hematological malignancy and not a carcinoma as a first pass simple explanation for all this. And that's further reinforced by the height of the LDH. So LDH can be elevated in any cancer, but it tends to be higher in liquid tumors. So that hypothesis is reinforced in that sense. And then you probably pause for a moment and say, anytime that I have anemia and I have a tricky a neurological case, I should think about B12 deficiency. but I don't think I could take it much further. Why? Because I know that in a short period of time, I'll be able to understand the nature of the neurological issue. So why would I hamper myself by trying to understand the overlay between anemia, hemoglobin, and all of neurology, instead of understanding the overlay of anemia, leukopenia, and a specific neurological lesion? So I wouldn't take it past that, but ask, what's the receipt of chemo? Is it actually a liquid tumor? And let me just send off a B12, because that is really, really easy and simple to address, and wouldn't think beyond that right now. Prof. Rez.
I'm still muted because I'm trying to think, how can I use this word camouflage? What a beautiful and attractive word. I love it, man. I wish I was at that VMR.
We made progress, didn't we, on the words? We made progress.
Way more attractive than the word. I'm going to camouflage into the background as I let you nail the diagnosis. But I want to just highlight one other thing. For those of you who are in the audience and are nervous about presenting, look how great of a job Nikita did. She doesn't have every single lab value, but she doesn't need it. If you listen to RLR on our Patreon, like Robbie and I never present every specific value. The goal is to give the general themes and allow for the exercise to unfold. So I just want to thank Nikita again for volunteering to present, and she's provided us more than enough data to try to reach a reasonable conclusion. And I think this is where medicine is beautiful. And every day we're growing, but here we have calcium. This is significant hypercalcemia, and we have to incorporate it into our problem list and into the final answer. So you have hypercalcemia, you have a schema for that. You have bilateral lower extremity weakness, you have a schema for that. You have pancytopenia, you have a schema for that. So what would I advise? This is what I would advise. The schema that you're most comfortable with, start there. So let's say you say pancytopenia. Start with your pancytopenia. You're like, okay, there's splenic sequestration, but that wouldn't explain the hypercalcemia. That wouldn't explain the lower extremity weakness. There's peripheral consumption, but we have a central marrow process. So the pancytopenia has to be something involving the marrow. It has to be. So then you sort of go further along that trail. Or let's say you start with the hypercalcemia. You're like, okay, I know the first step in hypercalcemia is this PTH mediated or not? When has a PTH adenoma caused this much havoc? There is some, unusual circumstances where you can get brown tumors and severe hyperparathyroidism, but this is unlikely to be PTH mediated. So now you're in the non-PTH, and you're like, okay, non-PTH, could this be vitamin D excess? No, it can't be. Then you're like, well, can this all be granulomatous? Can this all be granulomatous? Because right now we're saying cancer, and lymphoma can cause granulomatous lesions. Lymphoma can cause a high LDH. Lymphoma can cause spinal pathology. And you should never say it can't be lymphoma. But when have granulomatous lesions cause this type of spinal havoc or this type of havoc? Really, granulomatous lesions in the spinal cord, they don't really manifest as weakness. They manifest as hypercalcemia. They manifest as a biopsy showing granulomas in the spinal cord. So then if you had to choose between granuloma and lytic, lytic is probably what's going to be more likely, lytic, but you can't ignore PTHRP and paraneoplastic phenomenon. You can have both METs and PTHRP. And whenever you see anemia, renal insufficiency, hypercalcemia, weakness, you have to think about multiple myeloma. And the truth is, in multiple myeloma, despite the acronym that we use in the United States is CRAB, C-R-A-B, hypercalcemia, renal insufficiency, anemia, bone disease, the creatinine renal isn't something you see at first. That's usually later on in the course. The hypercalcemia is not something you see at first. That's usually later on in the course. So this would have to be advanced aggressive stage myeloma if it were that. But why invoke yet another malignancy when Nikita told us there's a carcinoma? So putting everything together, my top consideration here would be some kind of metastatic disease leading to lytic lesion, causing pancytopenia, LDH through increased cell turnover. Next to that, that lytic lesion would be related to the carcinoma or myeloma. After that would be lymphoma. But once you're in an area which is endemic for tuberculosis and someone has been immunosuppressed, you have to entertain the idea of TB, though the TB doesn't really explain the LDH elevation. So I think less likely. Robbie, I actually want to pass that. We still have some time. So I want to pass it back to you to dance with me and let me know where you are using, because each of us look at the data a little differently with regard to our comfort.
I am gonna transpose myself and camouflage right behind you because I have nothing to add. I think completely.
Oh, and Robert, that's a terrific point. You're absolutely right that the patient does have urinary retention, may have overflow incontinence, and so you could have an obstructive uropathy to explain the renal insufficiency. And that's why that renal insufficiency never takes center stage in the number of findings. But thank you for that alternative explanation.
I'm gonna call you Robert now forever, by the way.
Who is it that was you?
Rob Weber is an outstanding third-year resident at UCSF. It is your birth name. All right, Robert. Talk to you soon, Robert. Bye, Robert.
Wait, hold on, Robert. Can you unmute yourself and,
Yes, Robert.
let us wish you a happy birthday? But two, what do you go by?
Well, I go by Rob. I'm just joking around.
All right, Rob. I'm going to give you all the compliments, especially now that I know it's your birthday. The most stellar
He said birth name, but let's make it his birthday. Let's make it his birthday.
All right, I'm going to stop now while I'm ahead. Hey,
Save us. Please.
The coffee is kicking in. Bobbert. I like that, Bobbert.
Okay, so at this point of time, after I spent a significant amount of time with the patient and his wife, there comes this child with the reports from 4 months ago. So in these reports, I see that his hemoglobin is low. It was around 10. His LDH was around 400. His creatinine was 1.5. His calcium was 10. His ESR was 74. A urine analysis was done, and they found out that he had cloudy urine, and a urine dipstick test was done for protein, and that came out to be negative. And after going to the reports, I finally came to a point where I saw that an electrophoresis was done, and it seems that there was a monoclonal peak, and a confirmatory bone marrow biopsy was done, and it showed clusters of plasma cells. So by going through these reports from 4 months ago, I got to know what's the likely diagnosis. So I'll stop here before the last aliquot, which will say the complete diagnosis.
Wow. Amazing exercise. Thank you so much, Nikita. So just really quickly for the audience, when you perform a serum protein electrophoresis, this topic used to really confuse me. What you're searching for is there a gammopathy? And not only is there a gammopathy, but is it polyclonal or is it monoclonal? Polyclonal meaning that you see, a number of spikes, and you might see if you think about it, any inflammatory process will, without selection, cause propagation of B cells. These B cells release immunoglobulins, but it's different B cells. So you get polyclonal gammopathy or polyclonal immunoglobulopathy. But if you have a single plasma cell, then that plasma cell only knows one immunoglobulin release. It's either IgG, IgM, but a specific type. And that's referred to as a monoclonal spike. And that suggests a plasma cell dyscrasia, and in specifically myeloma, but there's other plasma cells dyscrasias from light chain disease to Waldenstrom's to even multicentric Castleman disease in the idiopathic form, though it's not really idiopathic because it's poems associated. All that's to say that this is consistent with myeloma. And so now the question is like, what kind of myeloma? Is it IgG, which I believe is the most common? And yeah, but let me, and then you think about the complications of myeloma. You are in an immune compromised state. So you're at risk of infection. You're at risk of bone fracture. In fact, this is one of the most devastating presentations of myeloma is bone fracture and spinal cord injury. But let me pass the mic to Robbie to sprinkle a little bit of his knowledge too. Robbie, please share with us some special stuff.
You got it. I don't have anything special to add.
You can't camouflage anymore.
I would just say, if you ask yourself what's unusual about this case, there's literally nothing except the leukopenia. So that's something to think about as this, if it's a complication of the treatment. And then, you know, I think that yeah, I think you're still, you know what the cause of everything else is. And now the step is to tie everything together and ask yourself, what is the CNS manifestation? What is this, a compressive neurological issue? So getting an imaging of the cord, or were we wrong about that? And is this the paraprotein causing a non-compressive paraneoplastic myelopathy? Of course, that has tremendous implications for the patient, right? Because if the patient has compression, he would benefit from surgery. But if the patient has paraneoplastic neuromyelopathy from the paraprotein, you have to really, really aggressively treat that in a different way. So I think now you've diagnosed multiple myeloma because you have a paraprotein and you've proven that there are consequences, and the consequences are the Crab criteria, and you have a bone marrow. In fact, you have more than you need. In fact, actually, you know, since we have time, let me show you a visual. Ironic.
This is, he said, I have no special sauce. This is all
No, I have. You know what's really funny here? I'm going to actually show you the date on this.
You're like a tooth fairy. You're just sprinkling, or is it not the tooth fairy? The one in Captain Hook. What kind of fairy was it that was like sprinkling magic dust? That's what
you're asking me a reference about culture.
Tinkerbell. Thank you so much. Yes, you're Tinkerbell right now, Robbie.
All right, come Tinkerbell with me. Look, by the way, look at everyone. Look when this note was created and when I made it today. Anyway, it's because we have an interesting case on our team with somebody with a monoclonal protein. So when you have a monoclonal protein, you can come up with all sorts of different diagnoses. Myeloma as example, plasmacytoma, MGUS, all sorts of things. But so where are we? We have monoclonal protein and we have the Crab criteria. So that's all you need. You don't even need a bone marrow in this patient because you have the Crab criteria. The only tension is the reason that people get bone marrows is because you have to prove that these things are directly attributable to a plasma cell neoplasm. So you have to make sure that all these things are from the paraprotein. But here we also have this, and we have a bone marrow, and it's always a question of how much plasma cells in the bone marrow. So if you have over 60%, that's also another criteria to get diagnosed with multiple myeloma. So what can you learn from this? Know that when you have a monoclonal protein, you need to understand the status of the blood, the bones, and the bone marrow. And these three things allow you to make a confident diagnosis, and your options are actually pretty abundant. You can make the diagnosis of MGUS in some circumstances, smoldering myeloma, multiple myeloma, plasmacytoma, and then some idiosyncratic complications of a paraprotein. But here, I think as Reza outlined, you've sailed the diagnosis of multiple myeloma, and I think the tension now is the neurologic dimension of it paraneoplastic or direct cancer effect. All right, Nikita, back to you.
This was excellent, but the funny thing about this was that all of this transpired within 20 minutes of the ER visit. So before I could even get the first set of labs, because of my orthopedic interests, I was more concerned about, okay, why is this person not walking? So of course, we got an X-ray done, a thoracolumbar X-ray done, and we found out that there was compression fracture of the T12 and the L1 vertebrae. And there was also an abundance of bone lesions that were then confirmed to be osteolytic bone lesions. So so at this point, my job as a ER intern was done, and this case was handed over to MedOnco, and an MRI was done. And it was And it was confirmed that, of course, this patient did have like a thoracolumbar burst fracture. And it is due to the fact that he has an underlying multiple myeloma and all his neurological manifestations. And after seeing the MRI, they've confirmed that this patient, in fact, has the fracture along with conus medullaris symptoms because of the presentation of the symptom development and the neurological examination. So yeah, so this is basically a conus medullaris injury after the burst fracture of the thoracolumbar vertebrae. And the whole reason behind it is the patient doesn't have a solid bone structure because of his underlying multiple myeloma. So there you go, that's the end of the case.
Wow. Thank you so much, Nikita. What an exercise you took us through. And it just shows you the power of learning that can occur, even in a case where the final diagnosis almost becomes immediately available. So we are very blessed to have your interest in orthopedics, which brought you to this case, which then led you to present it to us. Robbie, question for you, my friend. Robbie put in the chat about like if it's greater than 10% plasma cells in the marrow, that require, is 60% the value you use for like a definitive like DX of myeloma? Because I never saw that, and I just Googled and I'm seeing 60%. So I'm just curious if you can expand on that.
Yeah, if you have, so blood, bone, marrow, not separate, blood, bone, marrow. If the blood is positive, so CRAB criteria, myeloma. If the bone is positive, you actually, it's complicated. If the marrow is positive, in the context of blood being positive, so if you have something in the marrow and the blood is positive, you only need 10% in the marrow. But if you have nothing else going on, no CRAB criteria, no lytic bone lesions, and you have 60%, then you can diagnose multiple myeloma. The threshold to diagnose it is lower, as low as 10%, if the patient has CRAB criteria.
And
So
do you usually see that in non-secretory myeloma, the 60%?
Yeah, exactly. Yeah. Or in oligosecretory myeloma, where you have a paraprotein on tissue staining, but you never pick it up on the SPEP or serum fluid light chain. So it shows up when you biopsy the tissue, but it doesn't show up because it's too small for the assay to detect it. Yeah, I'm really grateful for my for a patient and my team. We've had this very intriguing case that you will hear about, I'm sure, on RLR in probably a week or two when we figure it out. It's taking us on a deep dive of all the stuff. Because I won't go into details. So I've been like hours and hours of reading into this last 24 hours.
That's incredible.
Yeah. I just want to share one thing, Nikita, which is I think that you're really doing a marvelous job presenting the medical dimension of this case, but I think it also became apparent how unfortunate this patient's outcome and whether it's his access to care or access to quality care with this diagnosis of carcinoma is always a little tricky. And I just wanted to share with you all a little bit of like the reading the situation, which I don't think is something that is as definitive as the medicine. But think about this. Why do you think his family chose to use diapers instead of bringing him to the emergency room? And that's a question you should try to explore, because it'll lead you to being able to help them in some way, shape, or form. And the answers may be access to care, financial barriers, travel barriers, but that should be a problem on our problem list, not something that is just a medical fact. So think about that. And as Vikas just said, it might just be COVID, period. But for me, I wasn't honest about this, and I should have been. It actually was the real reason why I was suspicious that he had a chronic illness. Because I think it's not uncommon with patients with chronic diseases to have a much, much higher threshold to seek care when something even worse happens. You take a normal walkie-talkie person and you have them have overt paralysis, they're much more likely to go to the emergency room than somebody who has a chronic debilitating condition for months who's like, oh, one more thing, But at the end of the day, think about that and don't forget to address that. It's a powerful clinical reasoning tool at bare minimum to give you insight into what's going on, but a very important problem to put on the problem list, because it's not truly medical, but it's still something we can often at least address. Thank you for bringing that out and highlighting that, Nikita. I thought that was a really subtle but very powerful humanistic aspect to this case.
Yeah, as I mentioned, it happened during the height of COVID, and this person lived in an area that required him to take a boat in order to get to the city. So go on a boat and then get on the national highway and then get to the city. So he actually traveled around, say, 100 kilometers away from, he was 100 kilometers away from the hospital I was working at. So yeah, it was during the time lockdown, and it, this case, till this date, I remember this case always because it really did show like how COVID affected everybody, and this is the way it affected him. I couldn't really, I didn't really get to talk to the person, to the treating doctors regarding the prognosis of this patient, but I do know that in cases of conus medullaris with this presentation and a 14 days period, it's really hard to get the patient back on track. So I don't really know what happened, but yeah, it's quite an eye-opening situation that did happen to this person, and it was very unfortunate.
Yeah, I couldn't agree more with you. I said it so well. Thank you for sharing those details. All right, Maria, take us home, please.
Hi. I love this case. It had so many dimensions. Thank you, Nikita, for sharing. She reached out and she was like, this is neuro heavy. Can we still present it on a Friday? And I was like, neuro is my life. We can present it any day. I think it was very illustrative for a lot of points, both medicine and like humane points. So thank you, Nikita, for coming on Friday and sharing this case. So first, we started with a pearl from Prof. Rez that anyone who walks into the hospital with a myelopathy should be able to walk out of the hospital. And I think this dimensionalizes how we are so diagnostic heavy, but we also need to prioritize treatment sometimes. So you always need to have, we can get very involved in the diagnosis, but you always need to be concerned about what's important in treatment as well. And then we got very deep in neurology with the localization and tempo schema. So for bilateral lower extremities, you can really localize it anywhere in the nervous system, from bilateral brain lesions to muscle. So you need to start with the branching point so that you don't get lost. And the first branch point we saw here was localized weakness to either upper motor neuron or lower motor neuron. And then whenever you have different neurological components, such as in this case with motor and sensory, you need to consider high transit areas where you can just pinpoint a localization and then you can explain all of the symptoms. So in this case with motor and sensory, we started localizing to spinal cord, and then other signs really pointed to spinal cord, such as the sensory level. We found out about a cheating sort of trick, but whenever you have a localizing sign that doesn't fit with all of the others, such as the ankle hyperreflexia, try to take it out for a moment and try to like explain it some other ways, or even just disregard it. Not completely, but just for you to do the exercise with and without it. So for example, in this case with the ankle hyperreflexia, we saw that we could explain it with polyneuropathy, diabetes being like the most common cause worldwide, age-related polyneuropathy, or even localizing signs that can be affected by time. So we know that upper motor neuron hyperreflexia takes time to develop, so you wouldn't really see it initially. And whenever someone can pinpoint in time or an event to their clinical presentation, you also need to consider that as being like true localizing in time or falsely localizing it in time. And then you also need to find other very interesting ways in which you can support or disregard this idea. So for example, even though the patient had like this event falling from the bed where he could sort of pinpoint it, all of his presentation, he also had some signals that suggested a chronic condition, such as the diapers, which Robbie's very powerful reflection of how chronic conditions lowers the threshold to seek care in some situations. So don't be quick on assuming an event is the true starting moment of a disease. Then we had a lot of different other components to the case, such as cancer, which we have one of my favorite schemas, the cancer neuro Venn diagram, which we know cancer can cause neuroscience through structural causes, through paraneoplastic, immunosuppression, drugs, hypercoagulability. And then we had like this very like gravitational pull towards the case, which, that's when I saw like, this is why this didn't happen on Tuesday. Because the patient started having cytopenias and hypercalcemia. So neuro tends to have a big gravitational pull, but whenever you find more information, you really need to like change gear and reevaluate your problem representation and prioritize differential diagnosis. Start with the schema you feel most comfortable with, and then try to involve all of the other signs and symptoms into the picture. So a couple of examples from ProfRes, if you have the crab signs, even if you don't have all of the letters, try to think of multiple myeloma, which has a very important bone component, which can cause vertebral fractures, which could explain their neurosigns. Or this patient who had cancer and is from a TB endemic area could have TB, and then could also have vertebral TB, which could explain the neurosymptoms. Or carcinomas, which can cause meds, which can cause fractures, which can explain the neurosymptoms, right? So you need to find what pulls you in, and in this case, was the monoclonal protein positive. In that case, evaluate blood, bone, and bone marrow. There's other things with crazy names that are not multiple myeloma. And this is just a great example of how you need to have so many different ideas in your head, and then you need to like stick with one, prioritize one with all of the signs and symptoms, and go with it. So that was the final diagnosis: multiple myeloma causing burst fractures and conus medullary syndrome.
Maria, your teaching just absolutely phenomenal. And I say this as a teacher and someone who really like pays attention. It's so hard to teach when you don't have the video on, but the way you articulated yourself, the way you paused, the way you injected humor, a very powerful teaching. Bravo to you, my friend.
Thank you, and sorry for the video I had to run. Thank you for rest.
Of course, don't apologize. Well, thank you all so much. We hope you have a lovely weekend. Any final words, Tink? Tink, mathematician, that's you. Tink, any final words?
No, my what was it? Oh my God. No. I need to remember. I have an answer. No, my Persian rose. No. I'll explain later. Bye, everyone.